So we are going to have a very interesting case that Louis is going to present to us. If you can go direct to the slide, that's going to be a coronary case. You're going to
Aqui, ó.
share with you these very interesting images that we have. Louis, please.
Okay, so it's a coronary intervention here. You can present
Yeah.
next here. It's about a 69 years old male. The clinical presentation, false, that's a little bit peculiar. He has a stable angina with a class 3. So he has hypertension, dyslipidemia, he's a current smoker, and he's diabetic, and he's insulin dependent. So what he has in the past medical history, he has an anstomy in back 3 years ago,
Okay.
and he did an angiogram, and he was referred to CAB surgery.
So he had an angiogram.
Yes,
And at that time, 3 years ago, he was referred to bypass surgery.
yes, bypass surgery was.
After that, he had an MI.
Yes,
Immediately after that.
yes.
Okay.
I can imagine.
Now he's 69 years old.
Yes.
In that time, he was 63.
66.
So he had that surgical indication
Yes.
and he refused it.
Refused. He
Good.
formally refused twice. Not
That-
only once.
we usually to say the patient usually knows what's better for him,
Yeah.
for them. Patients,
Yeah.
they usually know what's better for them.
Yes.
Better than doctors.
Yes.
Is that correct?
Yes,
Okay,
correct.
okay, that's correct. Okay. Do you agree with this, Rodolfo? The patient usually knows what's better for them sometimes.
Sometimes.
So just I'm not just joking,
Yeah.
but sometimes they decide what they want to have.
Yeah.
This particular patient refused the bypass surgery 3 years ago. He's still in life.
Yes, we
But
didn't-
now what happened now?
Yeah, we didn't have access to his previous angiogram here, so what he was referred to our institution because he has a stable, but he was how can I say, they're really progressive.
Now he is very limited.
Yes,
Limited to
yes,
to
yes. Class
F4.
3 engine, yes.
Class
to
3,
four, yes.
just a
Slow-
regular exercise
yes,
or
regular-
even
yes. Small exercise.
more exercise.
Yes, okay. So next slide, please. So he's doing medication. He used aspirin, clopidogrel, atorvastatin, and anapril, carvedilol, and he has also using nitroglycerin. So when he has these symptoms,
Okay.
and trimetazidine for this class 3 engine.
Okay, so just 1, 2, 3, 4, 5, 6, 7 kind of medications.
Yes.
Okay,
His laboratory test is normal, normal renal function.
let's go to the echo.
Yes, echo. The previous echoes from
In that time.
Yeah, at that time he was a ejection fraction of 44,
So the
apical akinesia and moderate anterior hypokinesis.
so in that time probably he had an anterior MI and he had an ejection fraction of 44%.
Yes.
3 years ago,
Yeah.
without any other procedure,
No.
no revascularization.
No whatsoever.
Okay, what happened?
Well, from this 3 years, so he has referred. So with the next
Class 3
slide,
angina?
Yes, class 3 angina.
Oh, this AKG.
Yes, this rest AKG. We have slow progression in the arterial.
Okay, let's
This-
confirm that the MI was septal there. You can
Yes.
see a low progression V1, V2, V3.
Yes, low
Okay.
progression. And next slide we did.
And the T wave, can you go
okay,
back, please?
Go back a little.
Let's see the T wave in inferior wall.
Yes.
Oh, we have some T wave inversion in lateral wall. I mean, AVL. That's it.
Yes, that's it.
Okay.
So the next slide. So we did an angiogram. You can see a severe lesion in the proximal.
What is the percentage of this lesion?
It will be about 6 to 70%.
70%.
But he has an ulcer. You can see a ulcer here in the proximal.
Ulcer.
Yes.
In the right.
to the
Okay.
right. If you go to the next, and that's what you can see, appreciate the.
Did you do
lesion.
FFR or MFR in this lesion?
We could do it, but I didn't do on this particular one. But you can see there's a collateral from to the
Okay.
left system.
I can see that.
It's a grade 1 collateral.
Yeah, grade 1.
Grade 1 collateral.
To
next
the
one-
left.
Yes. To the
So
left.
we have a severe lesion to the left.
Yes.
That's the responsible lesion for the maybe the symptoms.
Yes, the symptoms of the previous presentation.
So the culprit lesion for sure is the left.
left.
Okay.
Okay. You can see it's a tight lesion on the ostium of the circ,
Uh-huh.
and perhaps a little bit moderate to severe lesion in the mid portion from the circ. And you can see there's some, how can I say, you can note the LAD has the lesion, but not on the
Well
trajectory.
defined.
Now defined, yes. For
Okay,
the next
let's go to the
projection.
next.
So that's,
Wow,
yeah. You
this
can
is an
see
ulcer.
that, yes, the ulcer and a really tight lesion is what would be the most important lesion, I think, is the
So if
angel.
you can summarize here, can you go the next one, please?
Yes.
Okay. So
Just,
let's summarize at this point.
yeah.
You have, what is the percentage lesion in the left main?
Left main, perhaps about 40 to 50%.
Osteocirc,
About 8 to 9.
8 to 9%. Osteocirc. LAD, 90.
90.
Okay. So this patient has 3 lesions. A very important lesion in the left system. Just to summarize to you. Left main is the first one. Let me look at. Left main is about 30 to 40%. Osteocirc is about 80%. And LAD, that perhaps is the culprit lesion, this patient has angina class 3, is about, it's almost almost a subtotal occlusion of the
95
lesion. So how about the LV function? Do you have you done?
Yeah, we finished. Well, the spider view, you can appreciate the
okay,
tight lesion.
great.
And the next one, I will say, was pretty normal to me.
Okay. So, without any kind of revascularization, no PCI, no bypass surgery, he had an ejection fraction of 44% by echo. That perhaps was correctly.
7.
Now it's about 70, so it's normal. That's very important for cardiologists, mainly interventional cardiologists. Sometimes they think they are God, but they are not. We have, this is a regular response. The LV function became normal after 2 years without any kind of revascularization. Perhaps, or maybe because of the collaterals that you can see only grade 1, but protect this LV function. So that's a very important. So what is your strategy for today? Let me ask you, do you have the next one?
No, there's not. Yeah, we did, how can these scores.
Oh, scores.
So it's
do you make decision by the scores?
No.
No.
It's, how can I say, to illustrate and...
How did you do this?
Yes, we just to show.
Just to show. Do you think the scores are important?
Yes, important. And
but the decision not based on them.
Yes, it's good to know how much.
Okay.
So, how big is the importance from this severe lesion?
What are the scores now?
Yes, the syntax score is 28.
28. Anatomic is so complex.
Yes, complex, but it's suitable to PCI. And the syntax score 2 will be equal, 8.3 in the PCI group and 9.6 in the CABG group.
The score 2 is just to review for you to
summarize.
To summarize to this, I think it's we have mortality if you do a PCI in a patient like this after 4 years in about 8.3%.
Yeah.
If you go to surgery, this patient is going to be 9.6%.
9.6.
So surgery is a little bit worse.
Yeah.
But it's not a huge difference.
No.
Only 1.3%.
Yeah.
So what do you decide?
Well, we decided along with the patient to do.
Because he refused the bypass surgery before.
Yes.
He still refused the bypass?
Yes, he still refused, but how can I say? He was a little bit more conscious about his condition now.
So we have 4 lesions: one in the right, one in the left main, one in the osteocirc, and one in the LAD. Rodolfo, what have you done so far? Do you have another images to share with us?
Yeah, we did the angel here, also.
Let's see the angel. The right we're going to take later. See, let's go look at the
it's
angel.
Really a challenge case. We have 3 bifurcation.
3 bifurcations.
Left main. Left circle with a marginal, and the LAD.
So do you think that the second lesion in the circuit is important too, or not? No.
If also we did a MIR4, if you I can do
okay, let's go to show the anatomic first, and you go later to the
angiograph. By angle, it's about 6%.
6%. See, let's go to the LAD.
LAD, we achieve a better view.
Look at
wow! Look at that. Yeah. Can you go do a zoom in that ulcer plaque? That's okay. Wow. Let me go there.
Yeah.
Okay.
And the spider view.
Wow.
Yeah.
Oh, the left vein seems to me it's more important. The lesion is more severe.
Yeah.
Hmm.
But the LAD here image false. It's how can I say?
So
the
Rodolfo said about 3 bifurcation because of the marginal branch.
Yeah.
Is
the
that
marginal
correct? Marginal,
branch.
the first marginal
Yeah.
branch.
We plan provisional stent in the marginal branch and the diagonal branch.
Okay.
2 stent, left main, treat with 2 stents. One
So what is our strategy to treat the LAD?
to treat first the left civil.
So there is some lesion in the diagonal too.
Yeah.
Perhaps
Maybe it's a
pseudo-
pseudo, né?
Uh-huh.
Pseudo-ostium.
Okay. Pseudo-ostium. Pseudo-ostium. Pseudo.
Yeah.
Pseudo-ostium.
Pseudo-ostium.
Pseudo-ostium in the diagonal. Severe lesion LAD. Left main and osteocirc.
Yeah.
So what you did so far?
We did image here, Fausto.
Image.
Yeah.
What kind of image you
We
did?
did IVUS.
IVUS. Even with the severe lesion LAD?
You can
Wow.
say we did. The image from the LED, it's, how can I say? It's
It's at least interesting.
yes, as
Okay.
long as the angel here.
Okay.
Can you show it, Fausto?
Can you show the IVUS, please? Who is gonna say about the IVUS?
Yeah,
Jose or you?
Jose and me, perhaps.
Okay.
So
May you have the IVUS in the screen, please? Okay.
So it's the circ here, Fausto.
Thank-
It's a huge
Mhm.
vessel. You can run.
Okay.
Say 4
So we
to
are
5
distal to the lesion in the LAD.
Yes, to
So
4
this
to
is the
5
circumflex.
Yes,
Uh-huh.
it's a 4 to 5 vessel, size vessel here, Fausto. And
We are in the circ or in the LAD now?
Plate,
circ.
plate,
The circ
circ.
first. Uh-huh.
The mid portion from the circ, and
Okay.
we did the moderate lesion here, Fausto.
Uh-huh.
And you can appreciate this really plaque burden. It's 74% of plaque burden here.
Uh-huh. So
But,
the
not
minimum
surgery.
luminary area is 3.74.
Yes, different
Okay.
because it's
Okay.
a huge
Huge
vessel here.
plaque
Huge,
burden.
yes.
Plaque burden. Okay, go ahead, please, Wagner.
Okay.
Let's go a little bit
Yes, faster.
faster, please.
So from the proximal, you can
The osteo lesion in the
yes,
circ.
from yes. And you can see it's the marginal here, Fausto, at 3 o'clock.
Okay.
Yes, coming.
Yeah.
No lesion.
How about the osteo circ, Wagner?
Yes, and the also
Also the circumflex.
Yes, that
Let's
we
see.
did.
Okay, that's a severe lesion.
Yes,
Okay,
the severe
it's
lesion,
very
and
close to the left main.
And we did
With some
it's,
calcium.
4.5 minimal area from the ostium of the circ here, Fausto.
Wow. So it's less severe than we expected.
Yeah.
Okay.
Now the LID.
And the
Image-
LED here.
And can you go to the LAD run, Wagner, please?
So from the
Now you're in the LAD.
yes.
Okay.
The mid portion after
The severe lesion.
yes, the
It's a
severe
huge,
lesion-
huge vessel.
yes, a really
It's about
huge,
almost 5
yes.
vessel, Rodolfo.
It's
Yeah, 4.5
5.
to 5.
Yes, so it starts to be a little bit more afflict. So when you go here, Fausto,
Mm-hmm.
you can watch, and appreciate. There will be
spontaneous
some- yeah,
contract.
Yeah.
you can- yes, at 11 to 12 o'clock, you can see the dye here.
Yeah.
That's inside the that was how can I say
In the wall.
Yes,
Yeah, dying blood inside the ulcer.
yes,
Like you see a dissection.
yes.
Mm-hmm.
The ulcer in the section. And the,
Wow.
yes.
It's almost a double lumen there.
yeah.
Now it's getting normal.
It's almost like a smoke here for
yeah.
So it's all
Yeah.
from the
It's a long segment.
yes long
Yeah.
segment.
Now it's going to come to be normal now.
Yes, yeah, perhaps not from the proximal LAD, it's because so it's a little bit calcified here, first. And we did also a measure from the ostium from the LAD. And this portion of the left
Okay.
main here falls. So
What-
that's the ostium from the LAD.
Very nice study.
Yes, and the 6.6 and the ostium from the and the distal part from the left main here. What Wagner is showing 5.5.
Okay. All right. So we finished the IVO study, and we have severe lesion in the LAD and moderate lesion in the osteocirc.
Yeah.
It's not so severe by IVUS. The minimum luminal area is 4.5, but with a huge plaque burden.
3.7.
370 distal.
Yeah.
374. Okay. Okay. So did you do any physiological,
Yes.
studying the circ. Just to finish, and we need to start. We have 40 minutes to do this case. Okay.
If you can show me the.
May you have the now the computer? I mean the MIFR in the screen, please. Is that possible? Is connected this computer?
Yes, connected. We tested. Here.
Okay, can you connect not the hemodynamics, but the computer that you have to measure the physiology? It's connected? Okay, no, this is the
The
slide.
angel plus the physiology.
Physiologic? Yes,
Yeah,
great.
thank you. Here,
Thank you.
So it's the angel here, Fausto, and we did a MIFR from the mid portion from the circ. It's about 72 here, Fausto,
Okay,
on this portion. And if you take account on the left
Proximal.
hand, it will be almost like 10.
yeah,
It's 0.10. That's a huge,
Huge.
mass
yeah,
of
yeah.
car territory under these two
So
lesions here.
you first were in the circ.
Yes.
So how was the measure distal to the lesion in the circ?
This just to the mid portion from
Yes, yes.
it's about 10 if you count
Yeah,
the
so it's more severe than we expected
yes
by physiological.
by physiology.
So maybe we have the left main and also the circ,
Yeah.
0.10.
Yes.
Okay, so the proximal part, let's go to the proximal just to see how.
No, this is the proximal here, false.
Yeah, yes. Before the lesion, just to show them before the lesion. When you bring that,
Yeah, here.
yes,
Here.
0.93, 0.94. That's a great jump.
Yeah.
From 0.94 to 0.1.
Yeah.
Great. Do you have a LED too?
The LED I can do now. Live.
Okay, let's do it live just to show them everybody the ischemia. It's very important. This technology that's come from Microport, and Daniel from Microport is here. Yeah, it's absolutely great. As Ricardo said last time, he said our reports now brings not the anatomic description of the lesions, but also the physiological. Louis now is performing there. All the fellows know how to do that now?
Yes.
Okay, good. Now Louis is measuring the lesion, the LED, the ulcer. Maybe he can have some problems just to
Yes, because it's not
do the contour, the perfect
Yes.
contour of the arteries, and see by the AI, the artificial intelligence is going to tell us how is the MIFR. MIFR, as you can read, just distal here. MIFR
Louis, more tight.
2D.
A little bit more tight, Louis.
Okay. Let's see. The computer is measuring now, so it takes like less than 1 minute. In this very hard case to do that because of the very eccentric lesion with that ulcer. Computing.
Yes,
Let's see.
0.10 again.
Wow, that's 0.11.
Yeah.
Yeah,
0.10.
0.10 or
0.10.
0.11?
0.10 here, false.
Oh, here 0.10. And how about this
Yes.
0.11 in the graphic?
In the it's because the
Oh,
sorry,
I see.
yes, yeah.
So that's 0.10. That's a severe ischemia.
Yeah.
That's the reason. So we have the clinical, angina class 3. We have the lesion by anatomic, by IVUS, and now by physiological. Rodolfo, the words are with you. Now, can you bring the angel, please?
We are using a 7-French catheter.
7-French
Femoral
by
approach.
femoral
The
artery,
radial approach is not good.
Okay.
To support a 7-French.
So did you cross the guide wire?
The LID with a workhorse, a BMW wire.
Okay,
Okay.
good.
Next.
It was easy to go through that lesion, that ulcer.
It's another BMW in left circle.
Circle. Okay. There's some prolapse there.
Yeah.
What do you did to avoid that prolapse? Anything different?
Okay,
No.
so just
Okay,
torque.
good.
Yeah. It's a polymeric wire. A pilot
And now a
50.
third guide wire
Yeah.
to the marginal branch.
Yeah.
And how about the diagonal? Are you
Yeah.
going to protect the diagonal?
Later.
Later.
Yes.
After
Okay.
treat the
Okay.
the cell.
So you're going to work and I'll talk to
Yeah.
Jose Henrique while you're doing this, okay? And Louis.
Okay.
So you're going to do the predilation now?
Later the
LED.
no.
The circle.
First, you're going to do
The
the circ.
lesion. Yeah.
You're going to treat circ first.
Yes,
The left main.
Yeah.
Okay.
Teste.
Okay.
Sobe.
Although there is a more severe lesion in the LAD, you are going to work in the left main first.
It's a 3-5 balloon.
3-5 balloon. Predilate the circ, osteocirc.
The lesion in the mid
Okay,
portion.
great.
Agora de ósseo. Olha lá.
So this is a 3-5 balloon by
12.
12.
Pode
12.
subir. Vai. 20.
Inflate at 20 atmosphere to do a
mais
predilation.
25.
Rodolfo is just preparing the lesion to receive the stent, and now we are going to tell you what's the technique, his intention. What his intention to.
Ok.
That's a good predilation.
Yep.
É,
Say good results.
How about the LAD? You're not
No.
going to touch there. So you're going to treat that later.
Yeah.
Now you're going to bring the balloon back. Pay attention there. I'll talk to Louis. What are you going to do now?
We are going
with
to
the
implant
lesion left circle.
Yeah, we're
Okay.
just going to put a stent in the mid portion from the circle here, Fausto.
Mid portion.
Yeah,
The second lesion.
yeah, second lesion.
No, direct stent.
Yes,
Okay.
Not direct because we did a little
But no,
dilatation.
the first lesion. So you're going to treat the first lesion,
Yeah,
the proximal lesion, because
Yeah.
there are two lesions in the circle.
yeah, the mid
You
portion, the proximal portion. Yes, correct, Fausto.
Not,
Okay,
not
okay.
osteo.
The osteo lesion.
No, we treat the proximal lesion. 4-9 o sente?
Yeah, you're going
But you did not predilate this.
4-9.
yeah, we did here, Fausto. We just
Let's see.
Here, Fausto.
Oh, okay. Oh, right here. I did not see that.
Yeah,
Oh, you're so
we're
fast.
so fast.
Yeah. So you did predilation both lesions in the
Yeah.
circle because you could see there was a jump in the second lesion
Yes.
in the physiological.
0.673. Remember,
Sim,
it's
so
10 if you according to the left man.
10 distal.
Yes.
So when you go between one lesion and the other lesion,
I did a measurement. It's 0.73.
70 the jump.
Yes, the jump here.
Okay.
Also, yeah. And it was a classic jump here. So it's a small.
So you're going to use a 4.5 balloon,
Yeah, we did. We
a 3.5. Now you're going to 4.5
No,
stent.
yes.
4.5
4
For
0
O.
by 9.
by 9.
Yes, false.
It's a huge vessel.
Yes, huge vessel.
By IVUS was almost 5.2. Huh?
Yes, yes,
You're going to pose a late.
yes.
Maybe.
We can use image here, also.
So now you're going to treat the mid portion lesion in the circ.
Yeah.
Let's see.
Bomba.
So it's a lot of work to do.
Prepara aí. Vai. Inflate.
So
Yeah, and just preparing this tank here first.
so we have 6 hands here to
Yeah.
work, or 8 hands. We have Rodolfo, Louis, Jose,
Pablo.
and
Yes.
Pablo.
Little bit. Assim, né?
So let's concentrate the position of the stent in the circ first.
Teste.
Okay.
Ok.
Looks good here first.
Sobe.
Okay.
Sobe. 2, 4, 6, 8, 10. Vai. Pode subir.
So they inflate the
20.
4.0 balloon by 9
Insufla.
in the circ.
Yes, at
Which balloon? Which stent was that?
It's the Inspiral.
Inspiral.
Brazilian.
So the Brazilian stent again.
1.
PLA, Sirolimus, thin strut. It's
Pegar
0.60
balão
or
4,5.
70.
Ou 5.
60 or 70. The
Six.
6. The
Ficou pequeno, né?
struts.
Tem balão
Now,
8, 4,5.
Rodolfo and Louis
4,5.
deployed the
468.
coronary stent
8,
in the mid portion lesion in the circ.
Vai.
Have you already tested?
Nope. We are going just to remove the because they are huge.
Now you're removing the balloon.
Yeah,
On the
from
stent,
the stent here.
you have the
We are going to do
hemodynamics
an
in-
angle test here.
Okay.
A control angle here first.
Teste.
So we have 3 guide wires, one in the marginal branch, one in the circ,
Okay.
and now one in the LAD. Now he needs to treat after this good kind of result. So are you going to post-dilate this lesion?
4,5.
Is a 4.5 here, Fausto.
4.5 balloon by 8.
By 8, yes.
4.5 balloon by 8 to post-dilate the mid-portion lesion in the circ.
Yeah.
for those who just came to us, this patient has angina class 3. He refused surgery 3 years ago, and now he's symptomatic, very limited to the exercise, and he had 4 lesions in the left system. Rodolfo and Louis are treating the first one, that is in the mid portion of the circle.
We are doing the post-dilatation here now, Fausto.
Excuse me?
We are doing post-dilatation here.
Post dilation at 20 atmospheres.
20 atmosphere
26.
with
26.
4.5 balloon after deployed an Inspiral stent in the mid portion of circle. Now we're going to test just to see how the results. Okay, great results.
Okay.
Looks good.
Looks good.
And now
Okay,
you need to tell us the strategy for left main and osteocirc. What are you going to do in the left main? Do you want to explain what you thought
We
about that?
plan
Wanna
use
say?
2 stents with a Culotte technique.
Culotte technique. Good. That's a good choice. Why did you choose a Culotte technique? Can you explain? Do you know?
We are talking here when you are doing the angel. You have to make sure you have a projection if you are trying to choose like a, how can I say, decay crush or
decay
nano
crush.
crush, because
Excuse me. Say again.
we are using the projection, and if you are trying to use a culotte, a decay crush with nano crush, you have to do a projection where you can actually see the osteum from the circle.
Oh, okay,
We're
so-
having some.
So there is an angel limitation.
Yes,
Yes.
correct.
And that's important. When you are doing a bifurcation treatment, you need to see very well into. So your technique depends what you are seeing by angel. And I could see that since the beginning, to look at the lesion in the osteocirc is not easy to see. So, and we are choosing the Culotte technique because it's the better position and the better
safer.
technique.
Yeah, safer because you can actually see that you are covering all the osteum. If you are
Okay.
trying to use the decay, you get too much.
You can miss
stent
the
to choose.
osteum
Yes.
too.
You can miss the osteum.
So only one, what did you say?
You can miss the osteum
Okay.
if you're trying to do the decay crush
Culotte.
technique and you don't have the correct view for it.
Okay.
Or you
So
can go too
wanna-
deep into
okay.
the
In
left
other
main.
words, they want to be sure they are going to cover the osteum of
Yes.
the stent. If you use a nano crush or DK crush or other technique like this, maybe you can miss even at a T stent. You can miss the osteum, even with a T stent.
Or
You can produce too much
too much,
into
yes.
the left main,
Yes.
and it would be a
In the
little
T
bit
stent
hard.
and a provisional stent, you can maybe have a protrusion of the stent to the left main.
Yeah, and it will be harder to. You can recross the guide wires
Okay.
and everything to do.
Now we are going to do a Culotte. So you're going to treat first the circ. De novo, pra mim. Sobe e dá uma apertada.
Yes, you're just now with getting with the stent
obrigado.
in the left main
Obrigado.
to the circ here, Fausto.
Certinho?
Oh, excuse me?
You're just the stent with the left main to the circ here.
Okay. So what stent do you have there? 4.5?
A 4
4 by 16.
4.0 by 16, left main and circ.
pouquinho para trás, né?
Needs to go a little bit distal or not?
Yeah,
Distal is okay. Just below.
Is there any lesion distal to the stent or not?
My IVUS know here, Fausto, we just at this osteum of the circ.
Okay.
When you got
So this
there,
is it's really hard to see, eh?
yeah.
It'll be
There is a superposition of the vessels.
teste.
Yeah.
Ok.
Okay.
Tá próximo, tá ok.
Now you're bringing back just to look at the osteum. If you make sure you are covering the osteum.
So it's
And-
the
and
yeah.
Take a look again in the circ,
Yeah.
osteo left main and osteo circ, just to make sure you cover everything.
Okay.
Ok.
Okay. Okay.
Go. Go.
Now you're going to up that.
10.
Can you show us?
Yes,
Inflate
up
the-
here. 10,
Oh,
12,
So
12.
4.0 by 16 millimeter stent is also an Inspiral.
Yes.
Okay. Inspiral, the Brazilian stent again. Inflate and deflate
deploy here,
pretty
folks.
fast. You cannot forget we are inside the left main. Bring the balloon back.
Teste. Pera aí,
Be
deixa eu
careful
centrar aqui,
with
deixa
the
eu
guiding catheter because you don't want to touch the stent in the left main.
Okay.
Rodolfo is working very carefully. If you look at his hand there.
We just did the angel, control angel here, folks.
No, yes, I could see that.
centrar.
That's a
The same balloon for
beautiful result. You're going to use the same balloon to overexpand the proximal.
distal
Distal.
first and the pot
Okay.
technique.
No, you're going to take the same balloon that you did the post dilation.
Yes, a 4.5.
Yeah, the 4.5 balloon. Now, what Rodolfo said, he's going to use the same balloon he used to post dilate the mid portion of circ to use in the left main and the osteo circ.
The ocean of the marginal, it's
Looks
perfect.
great. Yes, I could see
great.
that. Good result.
There is
So
no
the guide
lesion
wire
of
in
bias.
there help us to protect the marginal branch to be open and not occluded after you deploy the stent. Now, Rodolfo is bringing a 4.5 balloon to do a post dilation of the stent that was deployed in the left main in the circ.
Não, perfilado.
Let's see. So Rodolfo is advanced the balloon, bring the guiding catheter so carefully because he's doesn't want to touch the coronary stent that was deployed in the left main. Let's see if he can cross the lesion with this. I mean, the position is not so good if you use a
easy.
balloon. That's quite easy.
Yeah.
Great. Now he's distal to the stent. He's going to inflate the balloon inside of the stent without touching the wall
Ruim de ver, hein?
that
Ok, pode ir.
does not have a stent.
Okay.
So he's going
Okay.
to go with high pressure there. What's the pressure there?
Sobe.
It's 20 here.
25, vai.
How much pressure?
25.
25 atmosphere. Wow. A 4.5 balloon inside of the coronary artery just to get a good result. I'm a little bit scared when I go up to 25 atmosphere with a 4.5 balloon, even in a large vessel like this. Now he's brought the balloon back. He's proximal to the left main. Take the ostium. Is that correct?
Yeah.
Then post dilate over there.
Make sure.
Are you going to do a proximal optimization to recross the wire to the LAD?
Oops.
Yeah, we're trying to here, Fausto. Perhaps
Dá um testinho, só pra gente ver.
just when doing an angel here.
Are you going to do a post dilation again, the mid portion? Yes.
Just to angel. Okay.
Excuse me, what you did?
Little difficult to.
Yeah,
What-
we
what
did
they
a post dilatation in the.
We did the POT too. We post dilation at the distal part of the stent,
Não, balão 5.
Mhm.
and now we're gonna use a 5.0 balloon to do the POT.
Okay.
Oi.
So he used a 4.5 to
Yeah,
distal and also proximal.
Yeah.
And now he's going to do a
A
pot
5.
With a 5.0
Yeah.
balloon here, Fausto.
with a 5.0 by 8.
To achieve complete a position, the proximal
Struts.
edge
Okay.
of the stent.
Okay. But you're not going to touch the ostium with this, or you're going to touch the ostium too?
From the cert? No.
No,
We're
no,
trying
the
to-
ostium left main.
No.
No,
The
Rodolfo?
stent. The stent.
Yeah. See, he's going to do that.
All the stent.
Yeah, all this thing. Oh, he's going to...
In left.
Now he's going to do a post dilatation. Not exactly on the pot now, but he's going to overexpand the stent in the whole segment.
Yeah.
Yeah,
A proximal
Proximal to-
optimization. Yeah.
from the mid portion to the proximal. It's an 8 millimeter balloon length. Let's see how it looks like. That's good. I like this image now. Better. Yeah, you can see them how to work there. I'll be here.
Teste.
Okay, good. Now there's a 5.0 balloon by 8. He's going to do a proximal optimization,
Ah, já escorreu,
See?
tudo bem. Olha.
pretty close the bifurcation.
Isso.
So you're not touching the circ ostium, are you?
No.
No. Not touch the circ ostium. What's the atmosphere that you use there?
14 here,
14.
Fausto.
13. with a 5.0 balloon.
Okay.
And now he's going to expand the stent in the ostium up to 20,
No, 14.
14 atmospheres with a 5.0
The
balloon.
ratio
Yes,
by angle
He's
is okay.
working the bifurcation now.
yes. We're trying to use a 1-to-1 ratio here, Fausto.
So,
From the idea here.
so if there is no lesion in the LAD, do you need to place a stent since the whole proximal segment? Are you going to place a stent in the
Yeah.
okay. So you're not. So if you don't have a lesion in the mid portion, can you stop the procedure and finish it right now?
Yeah.
Sure. Yes. That's important point. What I asked the Rodolfo now. So may you have the camera here with the operators instead of the hands? Just to see. Okay, great. What I asked Rodolfo with, if we don't have a mid-portion lesion in the LAD, he could leave this bifurcation like this as a provisional, treating the circ. He said, yes.
Testinho?
But now, in this patient, he doesn't. That was only a simulation that I asked him. There is still a severe lesion, actually the most severe lesion in the LAD mid portion. As you can see, that retention of dye, ulcerate lesion, and this lesion is going to be covered by the Culotte stent he's planning to do. Is that correct?
Correct.
Okay.
You are trying now removing the marginal here, guide wire here, false, because
Okay, the margin, because you don't need it anymore.
yes,
Yeah.
we are pretty satisfied. We're safer.
So you're going to use this wire to cross the LAD.
Yeah,
So carefully with the guide catheter.
just not to touch the struts from the oxygen from the left main here.
Okay. Now he's trying to recross the stent where he did the POT, the POT optimization, proximal optimization.
Okay.
Now his treatment. He's with
Now
the
we
wire.
change the view.
It's very important
projection.
to change the view at this time because it's a very ulcerate lesion. You need to be just in that small room in the lesion. It's not easy to cross over there, even because you have a guide wire in there.
Yeah.
So you have just a small space to be in that portion of the lesion. Let's see now. This is a cranial view. He has the guide wire just close to the lesion.
Extreme cranial view, 50
Cranial view.
degrees.
If you look at the Rodolfo hands, you can see just he's very careful just to across that. We have some dye retention there. Is that the ulcer? See, the guide wire is going to the ulcer. Now it's getting through the LAD. Be careful. So there is a small branch or maybe the eccentricity of the lesion. Now he's trying. He got good.
Good.
Good. Good job. Now he could cross the LAD. Thank you. With the guide wire, he's going to bring the other wire out of the vessel. He's just very careful, avoiding the branches. Great. That's a great demonstration.
Okay.
He used the same wire that was in the marginal branch
Tirar de ar.
to go to the LAD. Since he finished the work in the left main bifurcation through the circ, he took the guide wire from the circ and brought another wire to LAD. That's important. Very important point. Now he is bringing back the wire from LAD. He's going to use this. He could use this if he wanted to the diagonal branch or not.
After open the struts.
Right? Oh, okay.
Vamos abrir a estrutura. Pega aí aquele 3, 3,5, talvez passe. 3,5, 12. Vamos lá, ó, o balão.
Qual?
3,5.
Now he's going to open the stent struts to the LAD. What kind of balloon are you going to use to open the
Também
struts?
2,5.
3,512.
2,5 de pré. 2,5.
2.5 balloon. You use the 2.5 balloon to predilate. Oh no, 3.5 you use.
Yeah.
So you're going to use a
Pegar também.
2.5 balloon to open the stent struts that go to LAD. So we still have about 18 minutes. Don't be rushed, but I think we have enough time to do everything. So we're going to use only one stent from the LA to do the culotte to cover a whole lesion.
Yep.
Okay, good.
Yeah.
And it's
our
important to
plan.
protect the diagonal to avoid any kind of
Trouble in the diameter.
thing that you are not expecting.
Yeah.
So now he's taking the balloon, 2.5 balloon by 8 to open the stent struts that goes to LED. Let's see how it works. Good. So Rodolphe is working now to bring the balloon, 2.5 balloon. So this is a very complex case. So
Challenge.
so that was studied by IVUS, by physiology, and also by anatomic angel. Let's see. Rodolphe is bringing the balloon to across. It's a 2.5 balloon. There is some difficult to cross the stent struts. Maybe a better position of the guiding catheter. You can get this. Okay, almost there.
Almost there.
Maybe we need a smaller balloon.
Yeah, perhaps.
Oh, you got. Huh?
Perhaps a smaller balloon here first.
No?
Deixa um balão 1.0.
Yeah. Some difficult.
Sobe. Beleza, vai.
So they are going to use a smaller balloon there. Because although the balloon is pretty close there,
Vai uns 15.
maybe you can just try now.
Vai 15.
No?
Vou ver se ele passa.
Let's see.
Pega o balão 1.0.
You inflate the balloon. Oh, yes, you got. You got now. Yes. So that was a very important tips and trick for this.
Yeah.
You just inflate the balloon with a 2.5 with high pressure. You just deflate,
Yeah.
like a Venturi effect.
Yeah.
You deflate the balloon and you could across the lesion. That was
Agora
good.
pega o 3,5.
Você não consegue pôr minha máscara aqui. Deixa o Rubens pôr. Não, não quero esse negócio. Não.
Tira.
Põe aí pra mim. Não, tá bom. Aperta aí, Rubens. Aperta pra valer. Que coisa de corintiano, pô. So
we're going to upsizing
So,
the balloon here first.
how much pressure did you use to open the stent struts?
I
20.
use 20 atmosphere. here
10.
first.
What are you going to do now?
We're going to use the
larger balloon.
3.5 balloon.
3.5 that you had there. So we used the 3.5 balloon, if you remember, to predilate the circ lesion. Circ mid portion, a circ ostium. This balloon is still on the table. Now he's going to be used to reopen, I would say, the stent struts to LAD. And also to predilate the lesion. Is that correct?
Não, deixa lá.
Let's see if you can get across.
Isso.
Let's see. So use the balloon. You open with the 2.5 the stent struts. That was not completely easy. Well, maybe you need to do the same strategy to inflate the balloon
15.
and deflate and see if you can get across. So you did that, already did that. You inflate the balloon to get a better position now with the guiding catheter and see if you can across the stent struts. Let's see what's going on. Now the guiding catheter is back. If you look at the Rodolfo hands, the guiding catheter is back so gently.
Okay.
And now he could across now the lesion. So you need to open very well this because you need to go with a long stent. If as you are going to do a culotte strategy, you're going to use a long stent to cover all the LAD.
Okay.
So you need to open these struts very well.
Yes, the cells I think
We went up
there's
to
20.
atmosphere.
Yes.
Good.
Vai ter
Let's see if it can go easily.
5. Okay. Inflate.
That's a good work on the bifurcation, on the stent struts. So the stent, for
Agora
those
tá bem, né?
viewers who just
Agora a
came
gente tem
to
que
us,
usar o diagonal.
there is a corner stent
Aquele guia.
from left main to the circ. Rodolfo did all the optimization, proximal optimization in this stent, and now he's trying to open the stent struts. He used a 3.5 balloon
So
to
we're going
open
to
this.
protect now the
The diagonal now.
Yes.
Now, after he opened the stent struts, he's bringing a new guide wire to protect that diagonal branch. That
A curva já estava boa.
has
a bit
a
more tip here, Afonso, but we did.
severe lesion, but Rodolfo thinks is a pseudo-osteon. Pseudo-lesion osteon. Let's see. You have the wire there. If you look at the Rodolfo hands, good. I like this camera. Both cameras. I like that. Rodolfo is bringing the wire, trying to go
Põe o rotor.
to. You have also the balloon there that you're going to do a pre-dilation. You're looking at the diagonal branch over there. You need maybe a small test there just to see the diagonal.
I will change the projection.
And now he's going to change the projection to go to the cranial view. That's much better to see the diagonal branch. Actually, it's the only view that we can see the diagonal take off. Now, seems to me he's pretty close, or maybe a little bit distal. He's distal to the diagonal. Yes. Let's see. A little bit proximal. There's retention of now he's in the diagonal. He got the diagonal very well.
Okay.
He's going to place the wire distal to the diagonal and bring the balloon to do the pre-dilatation. Is that correct?
Yeah.
Okay, perfect. Good. Luiz,
Vamos lá. Diagonal, circunflex.
puxa mais pra cima, puxa mais. Isso. Aí. Perto. Good. Let's see. What do we have there? So we have a wire in the circ, we have a wire in the LAD, and a wire in the diagonal.
Yes.
And he's bringing the 3.5 balloon to do a pre-dilatation there. Let's see if he can get
not
across
easy
that
to
lesion.
cross.
There was some calcium there. I could
Yeah.
see the IVUS. Let's see if you can across.
Yes.
The LAD lesion. Are you open there?
Yes, a little bit. It's a
Proximal.
really tight lesion here, Afonso.
There's a lesion there.
Use
Okay.
balloon,
Proximal.
Yeah.
tight lesion, calcium.
Okay.
So it's
Pegar
trying
o
to.
dois.
Let's see if you can get across. Maybe you need a smaller balloon
Yeah.
to open that lesion. It's so severe lesion, ulcerating plaque with calcium. Probably he had this lesion
Troca.
in
Pega o
3 years ago.
2,5.
Now we are going to predilate with a 2.5?
Yeah.
Yes, the same 2.5. So let's take a 2.5 balloon.
5 didn't
This is
cross.
interventional cardiology. Coronary case, a complex case, but just to work that. So be calm. We still have time to do a pre-dilatation and place a stent over there. Let's see if we can open with a balloon.
Right?
There was some calcium there, but that we could see by IVUS. If the lesion. Maybe Wagner can show the IVUS why they are working with this. May you have the IVUS on the screen? The LAD. Exactly in the lesion there, close to the diagonal. Is Rodolfo bring the balloon? Yes, just to see that. Good. And you can see, now you can see the huge ulcer there. Let's see the lesion, the calcium there. Then Rodolfo is bringing a 2.5 balloon. Let's see if we can, oh yes, good. He could across there, you see that? A huge arch of calcium
2, 4, 5,
there. And now he's inflating there.
8, 10, 12.
Let's see if we can open. Yes. What the pressure you use
It
there?
was 16 here.
Vai.
26.
16 here.
20, vai. Tira.
20.
20 atmosphere. So 20 atmosphere.
Teste.
And now you could see the IVUS where we are
Teste.
pre-dilating. Calcified lesion. Even with ulcer. So sometimes you see that calcium
3,5.
can avoid instabilization of the plaque.
3,5 lá.
Perhaps here.
We need to keep in mind all lesions have some calcium in there. See, this was the predilation, the small test. Now we're going to use a 3.5.
Yes.
So he still continue preparing the lesion. We still have some minutes. Don't be rushed.
Okay. Here.
Que coisa, hein? Não para, né? Por quê, hein? Tá ao contrário? Ah, por isso. Tá embaixo aqui? Ah, entendi. Burro. Burrice total, né?
Pode deixar.
Now, he's...
You're trying to.
how about the wire? The wire is
Yes.
still in the LAD or is in the septal?
Yes,
It's a septal.
Septal. Now,
not problem.
do you have... It's better to have the wire in the right place. Don't be rushed again, okay? Sometimes this happens, you are going during life. Now the wire is go to the diagonal, good. It's go to the apex, still to a diagonal,
Okay.
septum. So that's
It's
a...
okay here.
Oh, that's it's a good...
Yeah,
Yeah, it's good.
it's enough.
Okay. Now we have a 3.5 balloon.
3.5.
Okay. The lesion is a little bit distal.
Ok, sobe.
Yes.
Okay.
Good.
Vai, 20.
Up to
20.
16,
16,
20.
20.
20 atmosphere. Just that's a good preparation of the lesion. You can see the full expansion of the balloon. Full expansion of the balloon. And now he's gonna be
Puxar pouquinho.
bring the balloon back.
Só arrumar.
That's a very interesting case. I'm so excited to see this case here. It's impressive. Now he's 20 atmosphere again.
Yes, 20.
Okay, good preparation.
Okay, good
Now
preparation.
close to the diagonal, where we saw that pseudo lesion ostium in the diagonal. Deflate 20 atmosphere. Let's take a test or no?
Yes.
Just to see how it looks like.
Yeah.
Great. Let's see. Great. Let's see. Okay.
Ok?
Oh, that's great.
that's
Great preparation. Now we can maybe have the wire in a better position to avoid any kind of perforation or something like this. And also,
tamanho do stent,
I think it's good. You can see the ulcer outside of the lesion. And the stent probably is going to correct everything there. So what kind of stent do you prefer? What size is better?
It's
Asking.
4.0.
40 by 38?
Yeah.
Go. You need to go up to osteum, the osteum, no?
Yeah.
Or you're gonna measure this with the balloon.
Aqui.
We did some measure with the IVUS, but we can reconfirm with the balloon here, Fausto.
Yeah. Yep. So you did it with the IVUS. Did you measure from the LAD lesion to the osteum, Wagner? Maybe you can. I trust more the balloon.
Yeah.
So this balloon is
Pau aí.
16 millimeter, 15 millimeter length. The balloon.
The balloon, yes.
16 or 15?
It's a 15.
15. So the lesion is okay.
Just
Can you do a small,
the
small test there?
Yeah, the device will.
Okay.
Yes,
Okay. We can use the guide wire
It's,
now to measure.
yeah.
What Rodolfo is doing is he placed the balloon over there, pull back the wire.
30.
Wire is 30 millimeter length. Is that correct?
Tá bom, né? 33.
What are you discussing there? 33 or
Yes,
33?
the length, 33.
33 millimeter length. Let's see.
4,33.
Okay. So if you look at this measure, Rodolfo placed the balloon distal, bring the wire back. The wire tip is about 30 millimeter length. What he did, pull back the wire and could see that. That's a very interesting strategy to measure the lesion. And after this, so you can appreciate this image. We have, may you have the image there?
Yes.
Yeah,
even
you
from the
measure?
sizing?
Yeah, the size of the.
Yeah, here.
Okay,
Fausto.
yes,
Yes.
yes.
Deixa
Could you
lá,
keep this?
aqui.
Just okay, good. So we have 30 millimeter length from the wire tip, and now he's going to use a 3 millimeters
35.
longer than this wire. Okay, go ahead, please.
35
It's
here.
a 4 by 35.
Fernanda. Okay, we still have 5 minutes to finish, and now you're going to place
Stent here.
the stent. Puxa, isso, obrigado, aperta. Tá bom. So we have 5 minutes to finish, and you are bringing now the stent. The 40 by 33 is also a inspiring stent.
It's It's
No, it's
by Biotronik.
or
Ciro.
Ciro for Biotronik. So it is a German stent from Biotronik with a Brazilian stent. Two different stents. So that's a class effect of stents. Or Ciro is also a small struts, huh? You see about 60, 65 stent struts,
it's about
millimeter. Okay. Now Rodolfo is trying to bring the stent.
You know.
Maybe you need to open a little bit more the stent struts or not.
We did the test with the used balloon here.
Oh yes,
Fausto, and
good,
it was pretty good.
good. It's not just the. That's a good technique. Great.
And in this projection, I can see the tip of the catheter to avoid the
Touching the struts from
damage
the
the-
Austin.
Okay. The tip of the guiding catheter, you mean in the ostium. That's what you mean?
Yeah.
Okay. Now you have placed the stent there.
Fecha.
You're not going to inflate. That's a
Okay,
perfect
stop.
position to do a culotte.
Pode subir.
We are going to cover again the ostium, the circ
Vai.
ostium.
Vai, pode ir 20.
Now he's inflating.
Espera um pouquinho que eu vou pôr na
4 by 33 millimeter. We are deploying at 8 atmosphere or 7.
Não, não.
I did almost
The
14
LID
here,
is,
Fausto.
is
14.
approach. Yeah, vai lá. sobe.
14 atmospheres.
Pode ir mais,
Did you-
mais, 20.
Did you bring the balloon back or not?
Okay.
No, not yet.
20.
Okay.
The ratio is about 1.
One to one here for the ratio
Okay.
from the.
So after you deploy that, what is the technique to culotte? What are you going to do now?
We are going to do report and we will do recrossing and
The wire.
20,
Yes.
20. Desculpa. Ok.
recrossing the wire and do final kissing here.
Okay.
Teste aqui só
Okay.
pra ver o diagonal.
Can you see just the image? Are you going to do a test there?
Yes, just to see how is the diagonal here for stop the implanting the stent here.
Okay. Good.
Testinho.
We still have
Tá bom?
2 minutes.
Ok, o
To go?
diagonal is open.
Diagonal seems okay here, Faust.
Yeah.
After,
Yes, I could see that.
Film.
Can you repeat this injection? Okay, good.
Ok.
So the diagonal is perfectly open. You have a good distal
Agora eu vou.
flow, and the distal part of
sim.
the art looks great without any kind of dissection. And now, what are you gonna do now?
We are going
Change the
to do-
wires
Yeah, keep
Report
the
with a
5-0 balloon.
5-volt balloon.
before we change the wires.
Because the stents not well opposed.
Oh yeah. So we're gonna use a 5-0
Yeah. 5-0 balloon, report, and then we do recross the guide wires here, Faust.
to the circ.
Yeah.
Yeah.
How about the guide wire for the LED? You keep it.
Yeah.
Okay.
Now is the yeah.
Okay, let's do the report and try to recross the wire and finish with a final injection in the LAO. Maybe we have 1 more minute. I think we still have time. Now, you did the report with a 5-0 balloon at 25 atmospheres, and now he's bringing the balloon back, and he did an injection just to look at the result. And now, what are you going to do now? Recross the wire?
Yeah, recross the wire.
Pega o outro aí, Zé.
You're trying to take the balloon out.
Yeah, but it's a 5-0 balloon used here, Faust.
It's hard to take it out.
Yes.
Yeah, but you're gonna
Push
get
and
this.
pull back.
Good. But you can do that with 4 hands, very carefully, because you need to keep the LED wire there. And now you're gonna bring another wire to go to the circ.
Yeah.
Ou esse aqui mesmo, né?
We can
Rodolfo is in the
recross here.
diagonal branch with that other wire.
Vai ser ele vai. Esse tá meio sambado, hein?
So Rodolfo brought the wire from the LED, the diagonal branch, and now placing the distal circ. Good.
Complexa.
It was a good job.
Agora vamos ver.
You don't need to recross with the wire, because you have the other wire from the circ. You need to take it out. It's
Esse aqui que eu passou agora.
behind the stent struts from the LED. Are you bringing back the circ wire?
Yes.
Okay. So you could
have to-
take it out easily.
Yeah.
The circ wire.
Yes, just goes.
Now you're gonna do a kissing balloon there.
Yeah.
Pegar aquele
After
balãozinho
recross,
dois.
yes.
O balão 2.
Okay, you take it out.
Aquele balãozinho pequeno. O balão pequeno.
2.8.
So what are you gonna do now, Louis?
This is the guide wire that was on the circle. Now going now access the LED. And
How about
yes.
the wire that was in the LED?
Yeah, we just pull back to the circle.
The circ.
recross to the circ.
LED.
But you could keep the same wire in the LED.
Yes, we could, but we choose to.
But so you did it just to be faster. Is
yes.
that correct?
Yeah.
We cross through the struts.
Okay. But you could use the diagonal branch too.
Yep.
But it could be hard. Now you're gonna do a kissing with off kind of balloon.
Yeah, just we are
Start with
going.
a two,
Yes.
two
We
five.
need to finish now with this kissing.
Yeah, but we are opening the strut with a 2-0 balloon here, Fausto. Just because of the circ.
The circ.
Yeah.
Okay. So we are gonna open the stent struts with the 2-0 balloon. And after
2-0
we
balloon.
open the circ, we are do a kissing and finish the procedure. Is that correct, Rodolfo? Okay.
Yes. That's it.
Let's see. We have 1 more minute just to finish. They gave us 5 more minutes some time
Balão
ago.
3,5.
It's a long
Oh, it's
procedure.
smoothly
Okay,
here.
vai.
Good.
vai.
Really, really smooth.
Yes.
Ó, desinsufla. Vamos lá. Pega
Ok.
o balão 3,5.
You open the strut. You just open the struts.
Yeah.
Yeah.
What size of balloons you are gonna do the kissing balloon, the final kissing?
Tem 4 aí, não tem?
Yes, perhaps a 4 with a 4-0.
4-4. 4-0, 4-0.
2-4-0,
Yeah.
2-4-0. Good.
Pega esse aí.
So yeah, are you gonna do the final pot after the kissing or not? You don't need it.
The final point? Yes, we can do, but we,
You don't need. I don't think
don't
we
need.
need in the Culotte technique. You don't need to do the final pot.
Puxa.
That's
Estica. Estica.
what I usually do. So the Culotte stent, the Culotte technique, it's a very good. I think the anatomic, it's the most perfect result that we can get with all techniques. Even if you use DK crush, nano crush, mini crush, and everything. The Culotte is a lot of work, as you could see here. Now they have both balloons in both branches, LED and circ. Rodolfo is taking care of the guiding catheter so gently and try to
Dá uma pincelada aí. Dá
damage the struts from the stent from the ostium from the left main here,
uma
Fausto.
pincelada.
Yep. Just
what did you say?
we are just he's so cautious because you don't want to damage the struts
Oh yeah.
from the left main
Okay.
stent here. So it's almost on the ostium from the circ here.
Okay.
Fausto. Just
Okay.
little inflation here.
Circ ostium.
Oh, just smoothly here. You can
Okay.
appreciate. Yeah, that's okay here.
How about the LED balloon?
The lady are just going to put it on here.
Okay.
Menos até.
Let's see the LED if you can across there. You have the balloon in the circ, and now the balloon from the LED is coming.
Here, just
Mhm.
making the pre-dilatation from the ostium here, folks.
Open the.
Okay.
O balão 4 não.
Now we are going to use the balloon on the left.
Now we are bringing the
LED.
4.0 balloon for LED, and we're gonna finish.
Yes.
Okay.
4.5.
Okay. 4.5 balloon.
Yes.
Vai.
You know?
Nesse aqui, ó.
So we're bringing the 4.5 balloon to the LED. You have a 4.0 in the circ.
Yeah.
Okay. You are bringing a 4.5 balloon in the LED. Let's see. That's very important, and we're going to be finishing in 1 minute. Okay? And we'll do the IVUS, and sometime later we can show you and share with you. Be calm.
Não vai, né? Tem balão novo?
Don't be stressed.
Yes, 4.5 new balloon here. 4.5 por 8, por favor.
4.
Balão
4.
4,5.
You still have 2 wires
4,
in there.
8.
Segura aqui.
4,8.
Jogou?
Não vai. Tira.
Let's see. So you're going to try 4.0 by 8.
Yeah.
2 4.0 by 8.
Right.
We're going to be finishing now.
Yeah.
So just to review the case with you, this is a patient with triple vessel disease. He still has some severe lesion in the right that's going to be treated later. And we have 4 lesions in the left system. Actually, the right was already treated, and we are going to do we did a treatment now in the circ, 2 lesions in the circ, the ostium in the mid portion, and after this we did a Culotte technique treating the left main and also the proximal LAD. Now we are in the final part of the procedure to do kissing dilatation, kissing balloon at the end. And Rodolfo is trying to bring the balloon to LAD now. It's going to be a 4.0 by 8. Let's see. Now he is there. He's going to do the final kissing in the LAD and circ and also left main. What? How much atmosphere you're going to do this?
First,
Almost
24
here
first.
in the LAD.
LID.
20 at the LAD and are now circ
De novo. Vai.
about 20.
I just do here.
LAD.
LAD here.
We are dilating the LAD ostium, and now we're gonna.
De novo, 25. Segura.
Okay.
6 agora.
Finish.
Tá bom?
Circ
Circ.
and
Circ.
kissing.
Vai.
Now you're going to
Vai.
position for
Agora vai.
kissing.
6. 6 para cada um. Vai.
Kissing.
1, 2, 6 and the
6 in
Final
both
kissing balloon
balloons. Film.
8.
Tá bom?
Okay.
Deflate.
Great. And finish. Can you do it?